Hello and thank you for joining yet another episode of Transforming WHO. It's a series of videos where I talk to colleagues about reform and change in WHO, about the WHO transformation agenda. And today I'm joined by a colleague here from WHO headquarters in Geneva, Meg Doherty, who's the Director for WHO Global Programs for HIV, hepatitis and sexually transmitted infections. And thank you very much for joining, Meg. First, a little bit about yourself. I mean, you are a medical doctor and epidemiologist by background, American, degrees from Harvard and Johns Hopkins, and then of course also trained in infectious diseases. And I think it's fair to say that you have 3 decades of career now working with infectious diseases. Among that, HIV, which I kind of feel has been a large part of your career. We'll talk about that today. You joined WHO here in 2012 after working a decade in the field in low and middle income countries. Then you joined WHO working with technical normative work in HIV, and then in 2020 you became the director of our global programs. So we'll talk about that. But first I thought you would bring us back to the turn of the century, 25 years ago, and HIV. Because if we look at HIV as basically a global pandemic that's been going on for almost 40 years now, more than 40 years, I mean, sort of the peak of that pandemic curve is around the turn of the century, then it goes down. What was the change that happened there 25 years ago?
Well, I think there are many key moments that happened, but coalescing around one of the international AIDS conferences in 2003, I believe, in South Africa, under the leadership of Nelson Mandela, who brought together many leaders. And I think there was a moment where we realized we had a continent that was suffering from very low survival with HIV, that medicines were available in high-income countries, the medicines that treat HIV, that can prevent HIV, and that there was a moral obligation to start to bring those treatments and that care to people on the continent, and so that they could live healthy lives. And at that time, I think there were many different leaders. Of course, President Bush, who started with the President Emergency Plan, or the PEPFAR program, to start to bring antiretroviral therapy to 50 countries, but it started with a first cohort of countries, primarily in Africa. There was also WHO that launched the 3x5 initiative, which at that time, to get as many people on therapy, but to get at least 3 million people on HIV treatment by 2005. And I think that those were seminal moments. And then since then, that sort of architecture, Global Fund, Gavi, others sort of built up and really brought forward an approach that was focused on, I guess, what we call a public health approach. And it was WHO who launched that public health approach. Treatment that was accessible, that was harmonized, could be used in different populations, different age ranges, was at a price that countries could afford.
And also targeted at vulnerable populations,
yes, exactly.
The populations at risk and the situations at risk, and of course the countries with a high burden. Actually, you talked about the PEPFAR program, which is the President's program for AIDS. We have a photo here from 2003, which is an interesting year. We'll just bring out that. So this is the George W. Bush and his wife. They are in, I believe, Nigeria in 2003. 2 HIV positive mothers with their baby who's actually HIV negative, because there was a strong focus on preventing that vertical transmission of HIV, which is of course one of the great successes in that. And then very much by then, in the turn of the century, we had the science, we knew about the disease, we knew what worked, we were getting better antivirals. They were made accessible to patients in the north and the west, but not so much in Africa. And then by then, of course, the pandemic had shifted very much to the African continent. And then the PEPFAR program, among many other initiatives, have been hugely important. I'm mentioning the PEPFAR here because I think it's been mentioned as one of the program that has received the most funding for one single disease. It's more than $100 billion over these roughly more than 20 years that it went into that program. So I know that you worked yourself in the field for 10 years before you joined WHO. You worked for 5 years in Ethiopia on a Johns Hopkins program that was actually sponsored by the PEPFAR program. Is that correct? You must have been in Ethiopia around the same time as Dr. Tedros, who's now our Director General. He was the Minister of Health, so you must have bumped into Dr. Tedros back then. So you worked there for 5 years in Ethiopia. What did you do? What was your experience in working in Africa?
Well, it was a fantastic experience. And yes, Dr. Tedros was the Minister of Health when I was there. But it was at the start of, I guess, growing a PEPFAR program within Ethiopia. And I was the Director of Training and Clinical Services. So essentially it was a job of scaling up everything that one needed to do to serve a person living with HIV. It was about bringing the antiretrovirals, setting up the testing systems, working on the maternal-child transmission programs, working across tuberculosis and setting up the tuberculosis systems, laboratory systems. And we were in charge of multiple hospitals around the country, and then eventually health centers, and working with the community healthcare workers, which was one of the really, I think, is important pieces about the HIV response has been that it hasn't been left only in hospitals, but it was quickly decentralized, brought out to community centers, having people who are affected, civil society, leading on and bringing treatment and care, doing testing in
basically a system-wide approach
exactly.
with all stakeholders and partners involving not just one disease, one drug, but a system-wide whole sort of
and it also talked about, you know, we set up labs. We set up BSL-3 labs for tuberculosis. We set up supply chain systems. So it was the entire picture. And I think sometimes HIV program is thought that it's very verticalized, but in what PEPFAR has done, which I think has been one of the major success stories of public health. We talk about smallpox eradication. I think PEPFAR can be viewed in that line as well. That it has been building sort of an architecture of systems on which other diseases have built.
And speaking about ending the pandemic, that was actually another crucial moment around the time you joined WHO in 2012. And around that time, roughly 10 years ago, I mean, new ambitious targets were set for HIV. We have the SDGs being decided in 2015. One of the SDG targets is actually ending the HIV pandemic by 2030. And we also have around that time the 1990 target set by UNH, WHO, I believe also Global Fund is in that's of people with HIV, at least 90% should know their status. Of those who know they are HIV positive, at least 90% should be treated. And of those treated, at least 90% should have suppressed viral figures. I mean, that has since been increased to 95, so we keep on being ambitious, right? Another shift around that time, I forget when, but you probably know, is sort of the shift that we shifted into treating all patients with HIV and not only the ones with CD4 numbers. Was that around that time as well?
Yeah, absolutely. Yeah. And I think if I have to say one thing I'm very proud of WHO, and actually was the work that I was involved in with many other people in WHO, was actually moving from treating at certain CD4 level, whether that's the CD4 count, the level of immunosuppression, moving that from 250 to 350 to 500, and then finally treating all. And that was one of the, I would say, my most proud guideline that we made, because it was a critical guideline that allowed us to say everybody needs this treatment. And we don't need to rationalize treatment in any way. And I think since then, we've used that model of, you know, you have a virus living in the body, treatment is a good thing. And we do the same for hepatitis C, treat all, and eventually hepatitis B, I think we're going to be getting in that direction as well.
And it's basically also part, of course, it's for the patients, but it's also part of an endgame strategy of suppressing viral load and then by basically breaking the transmission cycle.
You're exactly right. Around that same time, the idea, I think when the 90-90-90 targets and then the 95-95-90 targets, as you mentioned, came out, there were a lot of people who were worried they were too ambitious. But as a matter of fact, if anything, I think it helped countries. Everyone knew, every country, even now, they'll know what percentage of their population has been tested, what percentage is on treatment, and what percentage is virally suppressed. And that viral suppression is about stopping deaths from HIV, but also stopping new infections and transmission.
A couple of other things that I think were game changers in recent years that really makes one believe in the end game. That is the introduction of the pre-exposure prophylaxis in risk groups, PrEP as we call it, and now we actually have an antiviral that you can dose twice a year, and then it will actually prevent people from getting the disease. So that makes an end game strategy, basically ending the pandemic, realistic in our lifetime, right?
I do. I personally believe it is realistic. And for example, we know from mother-to-child transmission, we already have 19 countries that have been certified that they've eliminated the mother-to-child transmission of HIV or syphilis. Now we're adding on hepatitis B. I think when we look at the data of where we are now coming into our midterm of 2025, 5 years to go to 2030, we have 1.3 million new infections a year around the world, 630,000 deaths. And to be able to reach, close to epidemic control, we need new tools. We need to reach a certain level of reaching that 95% of people on antiretroviral therapy, but also that prevention with lenacapavir, long-acting injectable prevention, could really be a game changer to try to even drive that down.
It needs to be made accessible, and it's quite pricey. Yeah. So of the more than 1 million new cases a year, I believe that 2/3 of them are actually in Africa. We actually have a slide just looking at the numbers we are throwing around here. This is a graph from the last annual sort of HIV report that you issue from your department. And basically, I mean, it looks good because the numbers are dropping. This is a number of new cases globally, and it's the death toll of HIV globally. But if we project it to the 2030 target, there is a gap. So we are not quite on track. Can you speak a little bit to why are we not quite on track? What's lacking?
Well, I think it's multifaceted. What we do know is now that most new infections that are occurring in what we call key populations, vulnerable populations. Populations who are men who have sex with men, people who inject drugs, transgender people, people in prisons, people who sell sex. So often at the most edges of society and marginalized. So ensuring that they have the full access to services is part of our challenge. Secondly, I think when each nation sees very low numbers of new infections, there has to be a system to be able to reach everyone where they are. And so I do think we can achieve it. But of course, we'll have to keep finding, those who are left behind.
But we know what to do. And you also have, I mean, you're working, of course, with this global health sector strategies for HIV, hepatitis, and sexual transmitted infections. That was decided in 2022, I believe, in the Health Assembly. But there's another challenge, very new, emerging challenge, and that's, of course, the announcement by the new US administration that they will withdraw from WHO. They are pulling back funding, not only for WHO, but also through the PEPFAR program and other programs. A lot of fund, and US is the greatest funding contributor to WHO, but also to many of these programs. So that must be devastating for you and your team working with this.
Well, yeah. No, I think it's a global shock. Let's say it's. I don't think it was expected, and so that it would have such widespread implications on programming. So I think also, it's hard to understand where there are people who've dedicated their careers, their lives across the board, whether they're in WHO or outside in other organizations, where suddenly all that excellent work may be lost. So it's also tragic. I think there are a lot of people mourning this, but I'll have to say, if anything, in the field of HIV, people look at problems and look for solutions. And already, there is a fantastic dynamism around civil society. They have set themselves up, having daily calls, finding out what's happening in countries, holding others accountable. And for WHO ourselves, what we see is, yes, it's a financial shock for us and for everyone, but our work is always about the person and the people and supporting the Ministry of Health. WHO's role is to convene with the Ministry of Health, to give them the best guidance. And when they're going to be facing a challenge, because they're all faced with huge challenges, multiple healthcare workers no longer able to come to work, clinics shuttered, drugs sitting on shelf that can't be delivered, people not able to get opiate substitution therapy and then having overdoses. I mean, they're real life consequences, and we already know anecdotally people are dying because of this.
The consequences are fairly immediate because of the stop work policies and basically drugs not being supplied.
So even though there are waivers, I think there's a sense, at least what we're hearing, is that it's got to be different. You know, being dependent on a single entity for funding is not realistic, and we have been working with ministries of health in countries for quite a while over the last 2 years on something called sustainability plans of how do we start to see HIV delivery or hepatitis or STI or TB delivery as part of what needs to be delivered through a primary health care approach, part of the health sector, and have full ownership of the Ministry of Health. And I think those sustainability plans are being developed. But now it's an urgent piece. And in our global health sector strategies, we already started thinking about what are the commonalities, how do we work more closely with primary health care. And we've been able to sort of pivot right now. We set ourselves up with in our department, but across the 3 levels of WHO, the regional offices and the country offices, our counterparts, a sort of a crisis room. And we're looking at what's happening immediately. What are the questions and challenges that our country offices are having or the ministries are having? Are we able to help solve some of those crises? We are collecting data on service disruption like we did during the time of COVID, as are other agencies, but then trying to triangulate them. We're working with the modeling consortium for HIV to say what could be the impact of how long this crisis could go on. And that helps makes a political statement. You know, we let this go too long, X number of lives are going to be lost. Our progress is going to be delayed by this much if we don't get this back on track quickly. And I think lastly, we've already set out to our country offices and our focal points, sort of recycling the guidance we had during COVID of what are the essentials? What are the essential health packages and critical elements that must be maintained while we get through this period of crisis? So I think everybody who's in this field has, I think, seen an optimistic view that, all right, we have a crisis, we have a goal, we have a mission. What can we do to mitigate the effects and maybe come out of this a bit better off, a bit stronger and less dependent?
And of course they look to WHO because we have a special role in the global health ecosystem as the leading and convening, as the specialized UN agency. So of course we're not the only actor in this field. I mean, we mentioned UNAIDS Global Fund, many other programs, but WHO does play a special role. So they look to us for direction and leadership.
Absolutely. And I think that's an important time that we show up at the ministry's office and say, what can we do? Here are some tools. Or tell us what tools you need, and we can work with our global network to bring you what you need. And I think it's that's the kind of conversations that we've been having with our counterparts. And I think it allows us to not look at the problem, because we're not going to change that financial shock, and we're not going to be able to change that pause immediately, but we can change how we work towards our goals together. And if anything, I think the communities who work in HIV, and meaning the multilateral, the civil society, have been so strong. And I could feel very depressed by all of this, or I could feel that we need to challenge ourselves to think about how we can do this differently.
Sure. And this also, we just had the meeting of the executive board of WHO was just the other week here. And basically what we heard from our member states is that we need to prioritize. I mean, they are concerned, but they are also very much saying, I mean, the gap left by the US funding is too big to fill. of course we will try, but we need to prioritize also in the way we are working. And I guess that's what you're speaking to as well.
Yeah, and I think, when we prioritize, but we have to be able to, as WHO, we may be in a very good place to ensure that we follow the science. Yeah. We continue to bring the new science to guidelines. We should never let that drop. And we may be in a position to make sure that we are talking about the gender issues, the other issues that others may feel unable to talk about it these days.
The current challenges which we are seeing and have seen for a couple of years is not only about funding, it's also about values. To be honest, you're speaking about what are the vulnerable groups here. Men who have sex with men, transgender, etc. That is actually also being challenged on these values, that we can actually, as WHO, speak to health for all, which we need to do, right?
And I think that's where that voice needs to come out strongly, I believe, and we need to follow the science. And people who have certain risks and more vulnerability, we need to shine a light on it and show what are the tools we can use to alleviate their healthcare challenges and their suffering. Yeah.
Last question. Multilateralism is also being challenged, and for some years there's been the discussion. We've seen it also in our governing bodies, and now certainly this is also very clear. It's not only funding, it's also like a deeper challenge to that kind of multilateral, rule-based international collaboration that WHO is part of. How do you see multilateralism, in this context?
Well, I think I started as a clinician, epidemiologist, and slowly being here at WHO, I've become understanding and more appreciative of how politics is so critical to allowing good science to come forward and good clinical care to come forward, or good public health care. So it's going to change, clearly. We're going to be in a different place, and I think we have to rely also on for example, we work within the co-sponsorship of UNAIDS with other UN agencies, and they're having the same challenges that we have, maybe at different extent to it. So we will work bilaterally as we need to with other UN agencies as this comes forward. I hope that we can make the case that we are an agency that serves all countries, and that we can continue to work in all countries and bring our voice, our guidelines, our strategies to all countries. But I also think there may be some opportunities for us to change the way we're working, and look to what are the innovations that others are looking at. What is the private sector going to offer us as we move forward? Can the work that we do in science also benefit from that relationship where we have some closer relationships with others who may be there to sort of, I guess, be other partners other than just member state partnerships or multilateral partners?
And exactly, the science-driven, data-driven, focusing on the impact and doing it in partnerships and not alone, that is certainly very, very key also to the WHO transformation agenda, and that's what we need to keep doing. Thank you very much for joining. I really enjoyed our conversation, Meg, and thank you very much, everybody, for watching yet another episode of Transforming WHO, and do stay tuned for coming episodes on this channel.